Hi, this is Susie Singer-Carter. And before we start today's episode, which is on the current state of hospice care, I wanted to clarify a few of the most recent facts because the topic can be so confusing, even for the experts. According to the University of Pennsylvania Leonard Davis Institute of Health Economics, there are ongoing concerns that hospice's eligibility and payment systems do not support consistent, high-quality care. They encourage profits over patients. Medicare's hospice benefit has become a topic of concern. In the year 2000, the annual Medicare spending has gone from $3 million to $23 billion. Today, 75% of all agencies are for-profit. It's reported that well-managed nonprofit hospice agencies yield an annual profit margin of about 5 to 6%, while for-profit public or private equity agencies yield about 18 to 22%. In recent years, the for-profit dominated industry has been the subject of investigations and exposés questioning the quality standards and financial practices. The issues revolve around racial and ethnic disparities. They also revolve around quality measures. While there are systems that exist to measure these, there's a wide variation in how they are applied, gamed, or even avoided by hospice agencies. In fact, Medicare's Care Compare reports that 47% of the quality data is missing. The number of hospice patients whose primary residence is in a nursing or assisted living facility has grown exponentially. Hospice agencies can't always control the quality of care because it's delivered by staff in those facilities. And finally, we are experiencing a for-profit downward spiral. In the early 2000s, some of the very best for-profit programs went through initial public offerings and became publicly traded. After that, we watched the hospice quality spiral down and the attitudes of the new management focus on finances. While there are still excellent programs, many of the for-profits maintain their high profit margins by skimping on services, tolerating unmet needs, shifting costs to families, short staffing on nurses, maintaining unreasonably high caseloads, and short staffing doctors. In fact, too many doctors are leaving hospice care. It's such a cruel irony to know that in the beginning, we created hospice in part to ensure dying patients had access to physicians. Now, a number of hospice programs have themselves become the barriers to dying patients being able to access their doctors. Having said all that, hospice has improved end-of-life care for millions of people over the course of its history. As with everything else in healthcare, more oversight and enforcement is required to ensure that everyone receives the quality care they deserve when and where they need it. And now, here's our episode.
When the world has got you down.
Alzheimer's sucks. It's an equal opportunity disease that chips away at everything we hold dear. And to date, there's no cure. So until there is, we continue to fight with the most powerful tool in our arsenal, love. This is Love Conquers Alls, a real and really positive podcast that takes a deep dive into everything Alzheimer's, the good, the bad, and everything in between. And now, here are your hosts, Susie Singer-Carter and me, Don Priest.
Hello, everybody. I'm Susie Singer-Carter.
And I'm Don Priest, and this is Love Conquers Alls. Hello, Susan.
Donald, good morning. How are you?
Good morning. I'm great. It was a nice weekend. We actually got outside, got to the beach area, which haven't done in so long. And so actually experienced what they call life.
Yeah.
Which is something we haven't been doing for the last 2 years.
Yeah, and it was actually very scary and very exhausting. That thing called life. It was really exhausting. Mm-hmm. We had my two little granddaughters who are 4 and under 2, who like 19 months, and we decided to take them to the Venice Pier, Santa Monica Pier. Which is literally on a summer day. It's like you're in some, I don't know, there was at least 100,000 people there. Like we just literally was like, it was hot and we're like making our way through crowds of folk and we're like so frightened that we're going to lose one of them or something's going to happen. But yeah, who knows? It's all up in the air. We did,
We did good.
We did pretty good. We
arrived with 2 and we came back with 2. So that's
came back with 2.
Great.
Yeah. Need to figure out how to go closer to bathrooms when someone is potty training. That was interesting. But thank God there was a lot of sand. It was like a kitty litter box for the 4-year-old. So it was great.
Oh my God. What a picture.
Yeah. Picture that, you guys.
Yeah, don't. Actually, don't picture it. But
Luckily,
it was great.
she's a go with the flow kind of girl. It
Literally.
was fun. Yes. Put him check. All right.
Yeah.
So I just want to jump in and just say I'm very excited about this conversation we're going to have today, Dawn, with
Yes.
with hospice nurse Penny, which you're going to introduce
Yes.
her properly. But I'm very excited to have a different point of view on the topic that we tackle. One of these topics in our documentary, No Country for Old People, which is the corporatization of our healthcare system in nursing homes, and particularly in the past, I want to say 5 years, it's really come to the surface in our news reporting and from the experts that hospice has become a big target for this corporatization because there's a lot of money to be made in hospice because of the way that it's structured financially. So, normally in a long-term care setting, Medicaid takes care of, if you're on Medicaid, it will cover your living expenses. So, but it only does that in a long-term care setting, not in your home. So then often people that can't be in their home and need to transition into hospice are therefore in the same facility, or perhaps a different facility. They may have to move. In my mom's case, it was the same facility now into a hospice situation. And so it's often now hospice is now taken care of via Medicare, and the amounts that they pay Medicare is significantly higher than Medicaid will pay. Medicaid is anywhere from like $250 a day to like sometimes $300, something like that. It varies across the country. But then, hospice can start anywhere from $300 and go above, well above $1,000 a day. It depends on what your, acuities are, where you are, what you need. And so, in the nature of hospice, and I just thought it's important to express what we've been, given as information for hospice, right? And based on the people that we spoke to for the documentary, which is it's really become big business, and because it is a comfort care program. You must be diagnosed from a doctor to have 6 months or less to live. You are provided, comfort care, anything that keeps you comfortable for however long you're going to live within that 6 months. And that doesn't include anything that's going to be a curative kind of treatment. So,
unless that treatment lends to the comfort, if it's just specifically to treat that to make it more comfortable for them, then there will be some of that. But,
right. The way one of our experts puts it, he said, if you have cancer, you're not going to get chemo. But if a tumor is you form a tumor and it's
causing a lot lot of pain or
hindering you from
yeah.
breathing or something like that, then they're going to they'll address that situation, but not to extend your life. Let's put it that way.
Right.
So what's happened that we've discovered in our research is that this kind of program can get taken advantage of because they're getting higher rates of billing. They can bill higher rates, and they can put less effort and less staffing and less resources towards this issue, or towards this program, and so. Often people are pushed into it or invited into this program earlier than they need to be, and then often are given less treatment than they need, deserve, and want because they're just kept comfortable. And so, and that's all due to the issue of understaffing. And understaffing is it's an epidemic, in all of our facilities, because that is the business model that the corporatization bases their business model on. I mean, staffing is the most expensive part of any business employees, and that is how they keep their costs down.
Yeah, and so therefore, in this scenario, hospice is not doing what hospice is supposed to be doing, and when hospice is done properly, it's amazing. It's a beautiful thing. But in this case, it's in these cases, it's being abused and not. So that's that's the position.
Right.
So
we wanted to hear the when it is a beautiful thing, and what does that look like? How does that look like? How do we get it? How and how do we not end up in a situation that my mom and millions of others have experienced? So, Teddy, that leads it to you, Dawn, to make an introduction of our guest that I'm really excited to talk to.
Penny Hawkins Smith is a nationally certified hospice nurse working in inpatient hospice, home hospice case management, hospice quality regulation, and education. During the COVID-19 pandemic, Penny found her way to social media, where she quickly realized that she had an excellent platform to bring education about hospice, using trends, humor, stories, and Q&As. Penny has found a wide audience and currently has over 2 million followers on social media. Known as Hospice Nurse Penny, her goal is to normalize death because, as she says, death is normal. And we're delighted to have her with us today. So let's not take any more time and say hello to Penny Hawkins Smith. Hello, Penny.
Hello there.
Hi, Penny.
Hi.
Thank you for coming and talking to us.
I'm so happy to be here.
Oh, good. I am so glad, because we met on TikTok, and you were very bold, and you responded to some of my posts like, girl, get it straight. You don't know what you're talking about. Da da da. And I'm like, what? Who is this person? I've been researching for 2 years. I went through this. Da 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 da. So I thought, we need to talk. I want you to come on the show and give me your point of view, because I think it's important, because if we can have a beautiful experience, then let's have it. I mean, we deserve it, right?
Yes, yeah. So many things I want to address.
Okay.
As far as the reimbursement, first of all, I want to acknowledge that there are bad actors, right? There are always, in any business, healthcare or non-healthcare, you can always have somebody who does unscrupulous things and takes advantage of people, and and that can happen in hospice, and it has, unfortunately, and of course a big deal is made about it when it does happen. But there are so many other hospice agencies that don't operate in that same way, and many of them are nonprofits. In fact, I've only ever worked for nonprofit hospices. So I know it sounds like this big business thing and there's all this money to be made, but the reality is routine hospice care only pays around, I think it's $270 or $280 a day per person. And it doesn't matter what we do for that person, we get the same amount of money for every single patient, whether it's a person who is in a nursing home and we're seeing them maybe every 2 weeks, the nurse sees them every 2 weeks, maybe the aide is going a couple days a week or 3 days a week. We get paid the same for that person as we do for somebody who's in their home who has 4 infusions running. I've had that person. The nurse is going every day. The chaplain is involved. The social worker, the aide is there every day. We get paid the same amount of money. It doesn't matter what DME we bring in, durable medical equipment, what medications we cover, everything. Like you're talking about palliative treatment. So let's say we have somebody who does have a tumor that's encroaching on their trachea, right? And they can't breathe, and we need to do something. So we want to do debulking with radiation. We're paying for that. If we're putting in a Plerex drain into somebody's abdomen to drain the ascites off, we're paying for that. And it still comes out of that same little $280 a day that we get. So, and then the other levels of care are also a flat rate. So general inpatient, which is what you were talking about, when somebody has a higher acuity, they might go into a hospital or a hospice care center or a skilled nursing facility so that they can have 24/7 nursing while we get their symptoms managed. It's really meant to be short term. The plan is to always stabilize and send them back to wherever they came from, usually their home, because when they're at home, we're not managing at home as well, and so we get them into a care center. I can tell you personally from working in care centers, there's no money to be made in a hospice care center. A hospice care center really usually has to be supported by an agency that has like a robust home hospice program as well, because that will carry the hospice care center. In fact, one of the care centers that I worked for had to shut down because it was a nonprofit. It had a foundation that was raising money for it. They were paying for all of this care and the rent and everything else, and it wasn't sustainable. It could not be sustained. There was just not enough money to be made in that. Also, you're talking about Medicaid, Medicare. If a person's in a nursing home and they have Medicaid paying for their room and board, and Medicare comes into the picture, Medicaid still pays for the room and board. Correct. So, Medicare, let me give you the caveat. I don't think the hospice program is perfect. I wish it was better. I wish that people could get concurrent treatment. People do.
Which means what, concurrent, just for people that don't know?
Let's say somebody has cancer and we know that they are really at the end of their life, but there's still some treatment they want to try. We should be able to bring them into hospice and allow them to continue that treatment, so that they can kind of make their own mind up about quitting. And it is an elected benefit. People elect hospice. Nobody's forced into it. They're not pushed into it. I think, Susie, you had said you felt maybe like you were kind of railroaded into it or coerced into it, if I remember correctly. And that's unfortunate, and that's bad. That's just people marketing, and I hate that. I hate that. People need to have an opportunity to really know what it means to elect the hospice benefit and to make that decision to come to that place on their own, in their own time. And it doesn't always happen that way, unfortunately. But
do you think, Penny, that when you say nonprofit, and I want to, I also want to give a caveat to nonprofit, because the experts that have done like forensic accounting on all different kinds of scenarios in terms of private equity and private equity like business models, which do actually cover 70% of our country's nursing home facilities. A lot of them, like my mother's, was to the public, it looks like it's a nonprofit. It's not. When you go deeper and you find out that just one portion of this corporation is a nonprofit, and that there's ways to get around it, and that's why all of these experts for decades have been calling for transparency, because it really is very difficult to find out who the actual owners are. And so there's all kinds of ways to game the system, and that's the problem, because there are amazing there's good actors and there's good facilities that want to do a good job, but they're beholden to their owners, what is between the owners and those facilities are, there's a huge chasm between them. So you have these, it's really legal money laundering. There's all kinds of related parties that the monies go through, and they own these companies. And there's tricks that, have been around forever in terms of this kind of it's corrupt system. And vulnerable people are targeted. That's the problem. And people and caregivers like me, when you are at a very emotional level in your life, and you're dealing with someone that you love very much, and so much is happening, and someone says this is where they should be, this is where they're going to get the best care that they need, and you're like, sign me up. Okay, I get it, And Dawn, you were there with me. It was exactly what you said, Penny.
Well,
it was like a marketing job.
Yeah, when you have a doctor saying this is where she's going to go, you don't know at the time. You don't have time to say, well, let me go down and start doing some research on this. Your loved one is sitting there, in theory on their last days, which is what she was told. So we don't have time to go and research what's the best facility, what's my best option. Education is so important, yet unfortunately people don't get themselves educated before all this happens because we don't know we're supposed to.
We don't want to.
You don't need not necessarily railroaded. You're
true.
just like, this is the only option. This is, as far as Susie knew, this was the option.
What was the best option as to
options. Yeah.
After this, avalanche of horrible things that were happening to my mom. And even though the doctors from the hospital were saying she can get back to her base, she's very strong, she's fine. Don't get so dramatic about it. Because I was like, is my mom dying? I wanted to embrace what was going on. No, stop it. She's not dying. Da da da. And suddenly I'm like, oh, she is dying. Wait, what's going on? I'm so confused. Meantime, mom doesn't want to die. Mom's like, I have no idea what to do. And all I want her to do is be not in pain and not to be a zombie either. Like, which is the best case? If we have to take her out, let's take her out now. I don't want her to suffer for 6 months. Mm-hmm. I certainly didn't want that, and so you're just not given enough information. And it also to the layman, I'm just giving this to you, Penny, is that it's very confusing as well. What's the difference between palliative? Is there a difference between palliative? When my mom was rushed to the hospital for the third time because they wouldn't take the Foley catheter out, and I was saying, I did research. It doesn't sound like this is a healthy thing. She doesn't need a Foley catheter. She urinates on her own. Sure enough, she's hemorrhaging in her bed, and now she's got to have blood transfusions, and now she's got to be flushed. And that doctor who was attending to her said she needs to go into palliative care. This is why she's not getting cared for. This is why she's not getting the care she needs, because she's in hospice. And I was like, oh, okay. Suddenly my mom's moved to another.
And it's the first time we heard that word ever. We did not hear the word palliative as an option before that. It was just basically hospice. So how did we get around that?
Palliative is not.
It's part of hospice.
Well, it's not part of hospice. It's
the umbrella.
It's the umbrella.
It's a completely separate program. Palliative is not any part of the hospice program. The hospice program is Medicare program. It's completely separate from palliative, but palliative and hospice are put together. Like, I am a certified palliative and hospice nurse, because palliative is, some people think of palliative as the stepping stone to hospice. It's kind of got a little bit of a similar structure as far as being interdisciplinary. Hospice is the first medical program that is interdisciplinary, which means that we have nurses, hospice aides, social workers, chaplains, doctors. There's a whole team of people. We do whole person-centered care. Palliative is similar to that. It's not just looking at the disease. So, Susie, when you're talking about the doctor is telling you she's not dying, you want to know, he's saying, nah, she's not dying. Oh, whoops, guess what? She's dying. I went through that with my dad, and I had been a hospice nurse for 5 years, and I kept telling them every day, I'm a hospice nurse. You can level with me. What is going on? Nobody ever said to me, here are our two options. One is to treat, and the other is for hospice. No one ever said that. And I kept saying, look,
exactly.
Okay, you're treating him for this. Okay, now he's got pneumocystis carinii. I do a little research. If somebody with immunocompromised system like he had from steroids from his lung disease has a 50% chance of survival rate. So I'm like, he's already got a terminal disease. He's got this infection that's got a 50% survival rate. The doctors are still telling me he's going to be okay. No worries, no problem. He ended up on a BiPAP in the hospital, and I called his first of all, I walked into the room, and my dad said, it's not looking very good. They're talking about hospice, and I might have a year left to live. And I said, that doesn't make sense, because hospice is a life expectancy of 6 months or less. Now, when I say they're talking, it's not hospice that's telling them this, okay? It's the doctors at the hospital. My mom says, we're so confused. Can you please call his pulmonologist? I call the pulmonologist. Yes, he had a respiratory crisis. If it happens again, we'll have to intubate him. I don't think he wants that. I said, I know he doesn't want that. I also found out no one had talked to my dad about his code status. He was still a full code at this point, and I know my both my parents did not want life, prolonging intervention. And I said, "Is it time for a hospice consult?" And he said, "Yeah, it is." My dad died less than 12 hours later in the hospital. And I'm a hospice nurse who kept telling the doctors that I needed to know what was going on because I could sense that something wasn't right.
Right.
And this is the problem. I mean, it goes deeper than just hospice. It goes into our whole medical system.
100%.
Doctors that are like, this is your only option. They tell cancer patients this all the time. This is your only option. Do everything. What if it wasn't? What if it's like not do everything, do something else? Like
Right.
no treatment. Like I can't tell you how many patients I've cared for who did treatment. It was futile. They died anyway, and they had a horrible quality of life while they were doing that treatment.
Yeah.
So,
Right,
and that's what hospice can do, is bring you a better quality of life. It's not
Right.
just comfort care, it's improved quality of life. It's helping people achieve their life goals, whether that's,
Right.
Getting married. We've had hospice weddings, a patient whose daughter was getting married, and his goal was to walk her down the aisle. And so part of our care plan was to get him the DME that he needed so that he could do that, to get his pain managed so that he could do that. This is what we do, is to try to improve quality of life at the end of life.
Right.
But the
It's so-
system doesn't allow us to get to that. I mean, our system is so difficult. You couldn't get there. You knew what was going on. Our system doesn't allow us to, or doesn't give us a big opportunity to get there because we don't know. And we asked
Right.
10 different doctors, what is hospice? And they all gave us a different answer.
Including-
They all
Because
gave
they
us a-
don't know. Because they don't
Well,
know.
including
Yeah.
hospice doctors,
That's a
including
problem.
But we had interviewed people from Medicare, Medicaid, hospice doctors, hospice nurses, lawyers who are also advocates from Canner. You might be aware of Canner, which is in Northern California. So they're citizens and attorneys for nursing home reform. They've been around forever, and they are there for the. They're not litigious lawyers. They're there to advocate for quality nursing home care and hospice care. And these are the things that we're hearing, is that what you're talking about is the ideal and what we hope for. But when I'm told, oh, your mom's been getting the wrong treatment, this is why, because my mom went into the hospital with a stage 4 pressure wound when the nursing home, a 5-star nursing home here in Los Angeles, didn't even tell me. And when she got to the hospital, they didn't want it on their hands. So they were like, your mom was just, she was just admitted with this. And so I called the facility. They said, didn't happen here. And I said, so when did it happen? I'm trying to figure that out.
I think it happened.
Yeah.
In the
So,
ambulance.
Of course, in the ambulance. So, so she was admitted with sepsis and everything else because they didn't take care of her. She had pneumonia. She was highly dehydrated. You're a nurse, and on and on and on. All of the comorbidities that happen with that. And so as a result, she was intubated, which she didn't need to be, but no one asked me because it was COVID. I couldn't get in. They gave her a G tube. They gave her a G tube without asking me.
Oh my God.
And then, so when we finally got her back after horrible things that, just an avalanche of things. And this is why I know I was meant to do this documentary, because why did all these things happen that shouldn't have happened? She's back at her facility in hospice with a G tube, with a catheter, and telling me that she's aspirating, so she's NPO, which is nothing by mouth. And I'm saying my mom is literally dying of thirst. She can swallow, have her assessed. Okay, we'll look into that. Is my mom going to see a wound doctor? Because the hospital said she has to have a wound doctor. I mean, even if she's dying from it, get a wound doctor in there and take care of it. Why should she be in that kind of pain? And why should she live if she has 6 months, which she did, horrible quality of life? We might as well, not to be dramatic, but to be dramatic, let's shoot her instead, because why should she live 6 months like a zombie? So, what do you say at the end of the day is that follow the money. why would you keep somebody alive in a zombie state? That's ridiculous.
So, yeah, and, in hospice, I mean, we don't do anything to prolong life, nor do we hasten death, but I don't have a whole lot of good things to say about nursing homes, because I have seen nursing homes keep people alive by shoveling Ensure into their mouth, every day, as long as they can get it into them, get them up, get them dressed, get them going, they get paid. That's how they get paid. Nursing homes and hospices are separate. I mean, I would be very reluctant to put somebody into a nursing home that owned a hospice, unless it's like a hospice care center, dedicated hospice care center, but like a nursing home that also owns a hospice. People don't know this, but you get to choose your hospice. You don't have to have a doctor's referral. You can self-refer to hospice, and you can choose your own hospice agency. You do not have to go with the one that you're referred to. You can look up the hospices online at the Medicare Compare website. You can look at their quality scores. You can see like who is available in your area. Something about California that I think is kind of not great, and it's different than Washington, is that in California, anybody can open a hospice. I mean, you can just do a hospice, right? In Washington, it's a certificate of need state. So you have to petition the state and show a good business case for why a hospice is needed in an area. In my area where I live, which is very, very rural, there is one hospice that serves this area. That's it. There are no others, because the state has said there's not enough people to support more than one hospice, which is kind of bad because we don't get choice. But the hospice that serves this area is top notch. It's one of the best in the state. So no worries there. But so when you have, like in California, these hospices that are just opening up right and left, and like you were saying about the nonprofit follow money, sometimes there is profit. Now, the ones I've worked for are truly nonprofit. They're huge organizations that put the money into other programs that are very underfunded, right? Palliative care is not funded very well, for one. But there are also for-profit hospices, and those are, in my mind, the worst, because they tend to put in a lot of things into place in the beginning, a lot of help, and then they pull back on it, so that's how they get their money. But so I think that's kind of one thing about California that's different. And unfortunately, so then you're going to get a lot more people who are trying to look for money. And again, there are some hospice agencies, we know about them, they were highly publicized, who have done things to get money. They've falsified certificates of terminal illness, and Medicare is constantly trying to improve the program. There are some things that they have done to really try to improve the program. One is they reduced the rate after day 61. So when a person is on hospice for the first 61 days, they get a little bit higher rate for routine hospice care. At 62 days and beyond, it drops down, because Medicare figures we get them into the program, we get all these things in place. Now you're just sailing along, and you can you don't need as much overhead. So they've done that. They're also now doing a pilot program where they're allowing some hospice patients to receive dialysis. Unfortunately, when people have kidney disease and they're on dialysis, they can't qualify for hospice if they're doing the dialysis. And when they stop the dialysis, they have a very, very, very short life expectancy, like 3 weeks or less. So they don't even get to benefit from the hospice program because they die so quickly. So Medicare is looking at that and going, maybe we can go ahead and do dialysis for a while for these people so that they can have an opportunity to take advantage of the hospice program. But the reality of hospice is, you have a life expectancy of 6 months or less. People can stay on longer than that. It happens a lot. We don't know when people are going to die. As long as they meet that eligibility at any given time during their hospice stay, they can be on. We've had patients on for 1 year, 2 years. I saw one for 5 years once. But the average length of stay is like 82 days. And the median length of stay is like 47 days. So people have this life expectancy of 6 months or less, but not very many of them actually reach that or exceed that. They usually die quicker. And that goes back to the hospitals not being willing to talk about, the D word that's going to happen to every single one of us. until the person is already like at death's door or close to it.
Yeah.
Right.
Yeah.
Go on, Don. Were you going to say something?
No, I was going to say you said one sentence a little ways back that was so important. You said, people don't know this, but you can choose your own hospice. Mm-hmm. That's exactly right. People don't know it because we're not told it. And also, as far as the nursing home and being owned, the hospital being nursed by the nursing home, that happened in Susie's situation, but they're named something different. The hospice has a different name. Right. So you think, oh, that's a different hospital, and this is where they, it's so confusing.
They're also under
so confusing.
They're also under a name. I can't say it because I will not say it on my show. But they are a very respected organization here in Los Angeles, and in the community, and so
it has a great name.
You think, oh, blah de blah. My mom's in great hands, and also, she's going to have the help from the nursing home as well as the hospice team. But the hospice team, it was, initially when we first met the social worker, it sounded like the best thing ever. And then like the doctor she told us, this doctor is she's a feminist rock star. She goes at least once a week. Well, she never met my mom once. She told me she doesn't in 6 months. She said she said, your mom's going to die. Let's take her off. I said, I want my mom off the G-tube. She can eat. She wants to eat. That's her life. She likes eating. Let her eat, please. And she said, yeah, I want to take her off, but then don't feed her. Let's just let her die. And I said, what is wrong with you people? And she said, I know you don't want to hear this, but that's my opinion. I said, but you haven't even seen her. And I said, can we get an evaluation? Let's evaluate this before you make a decision. We'll look into it. We'll look into it. And also with and then you get like, well, if you're not happy here, you can take her home. Well, no, I can't take her home now because her acuity is so high. Look what you did to her. You got her here when she wasn't like that. So, and it's not due to her Alzheimer's. This is neglect. This is the hallmark of neglect, right? And I know, Penny, that the way that you described it, which is why I wanted to talk to you so bad, is that's the way it should be. That's the way that it should be. And
the way you do it.
The way you do it.
You're breaking my heart, Susie. I have to tell you, I'm just about ready to lose it because what you got was not hospice. I mean, the fact that they told you that if they pulled the tube that you couldn't feed her, like. The hospice, Medicare hospice regulations say that we are supposed to be providing, therapists to determine these. They should have had a speech therapist come in there and
she
do
asked,
a swallow eval.
She asked for it every day.
I mean, like
Penny,
what you got was not hospice.
Penny, it took me 7 weeks to get a nurse to finally get it. Was on my mother's birthday 2 years ago on April 1st, and they finally got someone in because one of the nurses took pity on me. She was like, I'll call her in. The girl came in. I loved her. She was very sweet. But she did a 2-finger test and said, yeah, she can't swallow. I said, what? Wait a minute. Let me show you. I've been sneaking, drinks to her. And I show her, and my mom, because first of all, I was like, why do you have your fingers here? So I show her, and my mom's like, ooh, like she always did. And she goes, oh, she can swallow. Well, I'm going to allow you to let her suck on a sponge, but nobody else. Because I don't trust
not
that.
Hospice.
Staff can't do it.
That is not hospice. That's not what we educate about the risk of aspiration, and then if you want to continue to give that person something by mouth, then you can. Like we had a patient,
I wanted to sign something.
We had a patient.
She said, "I'll sign a waiver," and they said no. No. And
take her home.
If they take her home, then or finally they said, we don't trust any of our staff to do this, so it has to be you.
And
to do with the sponge.
I know I'm going to let you talk, Penny, but I just want to say that that since then I have, and this is, and you'll know this as a nurse, that G tubes cause more aspiration than anything else because it's actually food. It's actually coming up. Whereas if you're giving someone water or juice, we all aspirate on water every once in a while. It's okay. Anyway, go on.
Because tube feeding, because as the body's shutting down too, it's not going to absorb the tube feeding, and that tube feeding then I've suctioned tube feeding formula out of a trach out of a person because the family continued to want a tube feed even when the person was really close to the end of life. But we had a patient at our hospice care center who culturally they feed this like really thin soup at the end of life in this culture. And I don't remember, I think it was an Asian culture, but they were feeding soup at the end of life. And we just educate them, look, you know what, there's a risk, because this guy, I mean, he was pretty unresponsive and they're still shoveling soup in his mouth. And we just have to say, look, you know, we don't recommend it because he could aspirate. That's what we're just telling you, okay? And then let them, if they want to do it, they do it. I gave a guy a popsicle at the end of his life. He had been in the hospital, came over to the care center. I asked his daughter, how are you guys doing? She said, well, we're okay, but he really wants a popsicle. And I said, well, I can get him a popsicle. And she said, well, they said at the hospital you can't have one because he'll aspirate. And I said, well, he's on hospice, so. And she said, yeah, that's what I'm thinking. Quantity. So I gave him a blue raspberry popsicle, and he loved it. He loved it.
Good for you.
So like also, I want to say something about the hospice doctors hardly ever visit the patient. That's actually normal for the It's the hospice nurse who is the liaison. You know, like we are the ones who are there with our eyes and ears on the patient, and we report back to the doctor and we get the orders. And sometimes if it's a community doctor that's managing the care, we make the recommendations on things because we know better. And I always say, if you want to know when a person is more likely to die, don't ask the doctor, ask the hospice nurse, because we see it all the time. People and doctors in the hospital, they don't see it as much. They see it in the ICU. That's a very different looking death. They see it in the ER. That's a very different looking death than a natural death. You know, and so Dawn, you were saying, like, I said, people don't know this. The problem is, in the hospital, they don't speak for hospice because they don't know. And when you get your hospice referral coming in there, they're not going to tell you that you get a choice. They're supposed to. They should be saying, by the way, you don't have to go with our agency. You can find another one. But they're not. They don't tell you that if you don't like your hospice, like Susie, you could have transferred to a different hospice. They probably didn't tell you that. You can do that. The nursing home, just because the nursing home is owned by the hospice agency, and that's their hospice agency, you don't have to go with that hospice agency. They can't force you to use their hospice agency because your mom is in their nursing home. They can't do that. It's not legal. You know, so there's all these things. Like, you have the right to revoke hospice at any time. You can say, you know what, I'm done with hospice. I'm taking my mom back to the hospital. You know, like, people have the right to do that. And but yeah, not everybody knows that, which is why I'm on social media educating.
Which is why we're doing thank you. And that's why we're doing the documentary, because you also have rights to decide how you, as either you or your surrogate, how you want to, what kind of treatments you want, whether you like my mom wanted to eat, and I said she wants to eat, and we will sign a waiver of to mitigate any kind of responsibility on your part. We will take full responsibility. This is what we want. Absolutely not. Absolutely not. Now, I didn't know what my legal rights were at the time, because you kind of don't think that in this arena, in this kind of business industry, that you're going to be lied to what end. I didn't have my those lenses on at the moment. I had the lens of, how do I take care of my mommy?
Right.
And how do I make her have the best days of her life at the end, like as beautiful as possible. And it was, it is horrible to be out there floundering and not really knowing what to do. And you're only trying to do the best, and you're not trying to cast blame. You're trying to be a nice person, and you're trying to just, you really
because you don't want to ruffle feathers, and all of a sudden then there's retaliation. There's all those good things.
Oh God, people hated me after a while. I walked in and it was like, and I used to.
And you were nice.
I was nice. I used to go in and sing every weekend for the residents, and like I loved going and visiting. I walked in and it was like, it was like Frozen. Suddenly I was Anna, and I had no idea, but I could have been tougher. I should have been tougher. I should have demanded more, but I didn't because I didn't know my rights. And all I knew is that my mom, when the hospice nurse would come in or the social worker would text me and go, "Mom looked great. We were there today. She looks comfortable." I would go there later in the afternoon. She's in a hot room, facing a wall, hasn't been turned. The music that I asked to keep on wasn't on. She's lying there like a lump of rice, like nothing, like no quality of life at all. So
and also,
and
the
even
bedside manner also is so important. The beds of the nurses, because some of them literally treated her like a piece of furniture when they were like turning her, or whatever, like as if she wasn't even there. When they'd hurt her, like they'd cause something that would cause her pain, not like, "Oh, I'm sorry, I'm sorry, honey," and she would, you feel that. And that's so completely opposite. When I heard she was going to hospice, I had in my mind hospice in a comfortable bed. There's
it's
flowers.
Like,
there's music.
Yeah.
There's lovely nurses who care like you. And it was just so completely polar opposite. It was shocking. Mm-hmm. And I know that's not everyone, but there's still, like you said, there's a lot of unregulated, or when it's the same, facility as there's so too much of that.
Yeah.
How can we get more of what you're doing out there?
By knowing what you can ask for and knowing your rights. I mean, really, that's how. And nursing home. I mean, so like I know your hospice was awful, obviously, but also the nursing home part of it. Like, typically the nursing home is separate from hospice. So where I'm at, if I have a patient that's in a nursing home, I'm going in there to do my thing with the patient, and then I am managing the plan of care. But when I'm not there, I have no control over what the nursing home is doing. And I recognize that, you said something about 5 years ago, since 5 years ago, nursing homes have started to be bad. It's been longer than that, because when I became a nurse, which was about 20 years ago, I decided that I was either going to be a hospice nurse or I was going to work in nursing homes, because at that time there was abuse going on in nursing homes, and I thought, I want to go somewhere where I can really make a difference. Mm-hmm. So nursing home was my second choice, because there was so much abuse happening. We were hearing about it all the time.
Right.
My
That's
mother-in-law.
what our documentary is about. Yeah.
Wait,
Yeah.
I just want to correct you and say it wasn't the nursing homes that were getting bad in the past 5 years. It was hospice.
Oh, okay.
Because nursing homes have been bad for 50 years more. Yeah.
My mother-in-law is in a nursing home. It's owned by a huge. It wasn't when we put her there, but it's now owned by a huge corporation. We're constantly on their case, and I'm a nurse, so I know what to ask for. I know what to do. If I wasn't, she probably wouldn't be getting as good of care. But it's. You just have to walk in a nursing home and know that it is not the place to be. But like you, with your mom, Susie, we didn't have any other option. My husband and I both work. All her other kids work. It's a lot of care to take care of somebody. It's a lot of care.
Yes.
I was just going to ask you that because, people on social media who don't understand, haven't been through it, they'll say, well, I wouldn't do that to my mom.
Yeah,
She'd be home with me.
I would take care of her.
I would take care of her.
I'd take her home.
Yeah.
Like they took care of you. And I was like, oh my God, are you kidding me? This is my favorite person in the whole world. I would do anything for her.
Yeah.
I can't. There's some things that we can't do.
It's a lot of work. And I am a nurse, and I
nurse.
couldn't do it. My mother-in-law had an altered mental status. She went into the hospital. She was there for about a week, and they were, of course, trying to get her discharged as fast as possible. What's the discharge plan? I said, okay, I'm a nurse. We'll take her home. I'll take care of her. We'll do it. We'll make it work. She was at our home for 1 day. She was confused. And in the middle of the night, she fell. I called 911. I said, take her back to the hospital. The nurse at the hospital said, we're discharging her back home with you. And I said, no, you're not. She's not going back home with me because there's something still wrong with her. You discharged her too early, and we need her to be better before she goes back home, because we can't take care of her like this. and I am a nurse. So I am very sensitive to the fact that one, people have to sometimes put their person who they love so much more than anything into a nursing home, into an adult family home, or like a board and care, I think is what you call them in California, or assisted living, or we have to do it. And those who are able to take care of them at home often sacrifice their own health to do so. You know how you hear about somebody that died and then a year later their spouse died? It's because you have an elderly person who's on hospice and their elderly spouse is taking care of them to the detriment of their own health. And then now they're going to die because they were not able to, take care of themselves while they're taking care of their person. There is another problem with the Medicare hospice benefit. I will admit.
100%, 100%.
Absolutely.
I love the name of your documentary. What is it? No Country for Old People, right?
Old people.
Yeah.
Right.
Because it's true. It's so true. We have an aging population and we don't know what to do with them. People are living longer because we can make them live longer and keep them living as long as we can. And what do you do with them?
Right, exactly. That's the problem. There's ageism and ableism, and we have these people that, and that's why they fall prey to a corporate situation, because they're voiceless. There's a lot of misunderstanding, and the families, they want to believe. Who wants to believe their family member's not getting the right help, and who wants to believe that they're doing a bad thing? We want, that's why we look to these experts. I'm a writer. I write films. Bring me that. I'm your expert there, right? I'm not a doctor, but I did know my mom. And I did, as a human being, have instinct and intuition. I'm a mother myself. I knew when she's ready to die. I knew it. And I said, I will know when my mom's ready to die. 100% I will know. And I did know. And I told her the night before she left, I knew she was dying. I said, you taught me how to live, and now you've taught me how to die. And I think that she was a rock star, but she really wasn't ready. And that is the proof is that she lasted 6 months under such horrible conditions. And I fought for her so hard, and I couldn't make a change. So if we have hospice at home, and I've heard people in different states that I've interviewed that said, home hospice was wonderful, and other people that said it was awful. Like they didn't show up when they were supposed to show up. They didn't provide the kind of medication that they would hoped for. So do you think that home hospice is better if you can? And will you agree that there's sometimes home hospice is impossible for the families? Mm-hmm. Am I right or wrong?
Yeah, no, you're right. You're right. Home is the best place to be if you're dying. Who doesn't want to die in their own home?
Sure.
But it's hard for the caregivers. Ideally, there would be some kind of program that could pay for caregivers to come in. Now, Medicaid does do that for people who don't have money. And then if you have money, you can pay for it privately. And if you're someone like me who's right in the middle of the road, then you're screwed, right? You can't,
big time.
Middle America cannot afford caregiving, and they can't get the free help from the state. So we are doing all the caregiving. So, it really depends on the experience that the person has with the hospice agency, how good the hospice is. A lot of people have this expectation that they're going to have a nurse coming in, doing all the care, and that is not how it works. We are teaching the family how to care for the person. We're educating. We are normalizing, about what to expect so that they're not afraid. We're helping them learn how to actually do the hands-on care, and we do hands-on care as well. We assess, and we will do care, changing catheters, accessing ports, doing that kind of thing too, wound care, whatever. But we don't do 24/7 care. It's just the Medicare benefit does not allow for that. There's not the money for that, unless it's a continuous care situation, which again is like that general inpatient where we put someone in a hospice care center. It's very time limited. It is, you get, a nurse to come in and get these symptoms managed, and once they're managed, we're out of there, and we're just going to keep checking in. So, I hate to give people homework, but again, it boils down to understanding what you are entitled to through the hospice Medicare benefit, and knowing how to advocate for that, and knowing that, if you don't like what you're getting from the hospice you're with, that you can go to another hospice, and should also be reporting that hospice to CMS, to the Medicare
Right.
services.
Right,
Because
which we did.
Yeah,
we did
I mean,
that,
they
yeah.
should be reported. If they're not doing what
Of course,
they
their
should
enforcement
be doing.
is not, and CMS's enforcement.
This is the problem.
not-
That's why we're
their
doing the
oversight and
documentary.
enforcement
Yeah.
is not great.
It's the opposite of not great, and that's the problem.
Yeah, it's horrible
Yeah.
or non-existent.
Oh shoot! I had a question. Wait.
Well, while you're thinking, should I ask
Okay.
a question? Or you
Yes,
wanna-
go ahead, go
okay,
ahead.
so you where's the great resources for people to do their homework?
yeah.
Well, the Medicare compare websites like Medicare.gov compare dash. I can't remember what it is. You Google Medicare compare and you'll find it. And you can and this is not just for hospices. It's for nursing homes. It's for hospitals. You can put in your zip code and it will bring up all of the Medicare certified agencies in your area. I say never ever go with a hospice that is not Medicare certified. You want a Medicare certified hospice because even with as little oversight as they have more oversight than somebody who's not Medicare certified. So that's a start to be able to go and see like what are their ratings? How are they doing like in their quality ratings? The Medicare hospice program is very focused on quality of care, and we are required to have a quality program. That's what I do now. I'm a quality nurse now. We have to do performance improvement projects. We have to monitor data. There is a lot we have to do for quality of care with Medicare. The other thing you can look at is the National Hospice and Palliative Care Organization, the nhpco.org. They also have a lot of information in there for caregivers. So I recommend that website as well.
And you were saying so just to clarify, what we were told from all of our experts, the daily rate for hospice under Medicare is quite a bit different than what you were saying, Penny. So I'm just encouraging people to go out and do your research. How can we find out, how much our hospice is getting paid by Medicare? Is there a way to do that, like a daily rate that
it's publicly available? You can find it on the internet. It's publicly available.
Okay.
It's let me think of the name of what it's called. The something rule. But yeah, you can find
We'll
it.
put it.
And
We'll find out.
it'll give you the rate there's 4 different levels of hospice care. There is the routine hospice care. That's the one that's around, I think, $280 a day. And then there's general inpatient. That's the acute care. That's significantly more, like $1,000 to $1,100 a day. Again, very time limited. You have to meet criteria for that level of care, and they are very strict about that. Then there's a respite level of care. So, and this is another thing people don't know. If you have your person at home and you need a break for whatever reason, you need to go to a family reunion or a wedding, or you're sick or you're tired, you can put your person into a contracted facility with the hospice agency for 5 midnights, and that is covered by the respite benefit. That's for the family. And then there's continuous care, which is when they can bring someone into the home to, like I had a patient we did continuous care on. She was a young woman. We had all kinds of infusions going on her, and that pays more, and it pays per hour, not per day.
Right.
Yeah,
Okay. So that really clarifies that. That's really great to understand, because I think, and this is the problem, that because we don't know, we can get taken advantage of and be told that this is going to happen. Like when my mom was put into palliative, which honestly, like you just described palliative very, very differently, which is the way that I pictured it, is how you described it, is that, it's a separate program, right? And when my mom was supposedly transferred from hospice to palliative, suddenly she's on a different floor, and now a new social worker came in and said, now your mom, these are all the programs that are available to her, so all kinds of therapies. And by the way, nobody came in for them. I couldn't get them. It was just sort of just the rundown.
The
And
sales
then
pitch.
The sales pitch. And then and other experts who are in this field have said, they describe it different than you. So it's like the palliative is the umbrella for a hospice, for all kinds of comfort care. See, this is audience. This is why it's
different.
so different.
It's completely totally different. Palliative is also like you can have treatment while you're on palliative care. You can't when you're on hospice.
Yes.
Like they're
correct,
really
yeah.
closely linked, but they're not the same program at all. Not at all. Although some, like my hospice agencies, we do have palliative programs in my hospice. So, but it's not the same. It's not the same. It's completely different. We have a palliative program and we have a hospice program.
Right. See, that's how I pictured it, because I was like, okay, hallelujah. It's been 4 months and my mom's been suffering. She's going to go into palliative and now she can get a wound vac and a wound and maybe
and she
a
should
wick
have been. She should have
and
been
a
able
wick,
to do that. Yeah.
Right. And the whole thing that she actually needed that I was begging for, because obviously they didn't want to pay for it. So, this is what we were going through. I think it's.
Well, and it's not. In your case, I'd say they didn't want to pay for it. But we don't do wound vacs either, because, we do palliative wound care. What we know that, the skin is an organ. And when a person is dying, their organs are shutting down and they're going to get wounds. We have something called a Kennedy ulcer that patients can get, where their skin is it's beyond a stage 4. It melts away. You can see their bone. You can see their tendons. We can't fix that. Their nutritional status is in the tank. There's no way we can fix that. And so we do what we can do to make sure that the person is comfortable, as pain-free as possible. There's no smell, from the wound. We do what we can palliatively. So we can't cure it, and so that's why we won't do a wound vac. But also I want to tell you something. I know it seems like that the government's not doing anything about these bad actors. But I can tell you from my experience, and my agencies that I work for are top notch. There's nothing, we're above board on everything. Like we don't do anything we're not supposed to be doing. We've been audited multiple times. They read our documentation. If a person did not qualify for hospice, if they did not qualify for general inpatient level of care, we pay back money. Sometimes it's hundreds of thousands of dollars. Sometimes it's millions of dollars. It happens. More than one hospice agency that I have worked for has had to pay back money. The first one was probably about 16 or 17 years ago. And I will never forget, we weren't on an EMR, electronic medical record at that time. It was all paper. They were in our conference room. There were charts spread from one end of the table to the next, like all this long tables all pushed together with all these charts, and we had to pay back millions of dollars because we had patients who they said did not qualify for hospice. And did they not qualify, or whose mistake was it? So it was so here's the problem. It's like it's a mistake according to Medicare, but these are patients with dementia. And dementia is insidious. You never know how long it's going to last. It's very, very hard to prognosticate dementia patients, right? They can go for years with dementia. And you think that they're failing. And what happens a lot of times is they'll get an infection. And we have guidelines we have to follow that determine like if a person is likely to live 6 months or less. There's a special guideline that we look at. So they're failing. They get an infection. They go to the hospital. And we're like, okay, they're going to need to go on hospice. It looks like they're really at the end now. They get antibiotics when they're in the hospital. Then they come home and they're on hospice. And guess what? Those antibiotics kick in and they live longer. And we're like, ooh, like, what do? We need to kind of watch and wait a little bit. We need to make sure. Medicare says from the moment that you determine that a person is no longer eligible for hospice, you have to discharge them. Well, we're in this position where now we have this person in hospice. We've got all this equipment in there, support for the family. And are they just having a good little rally and they're going to dive again, or what's going on? It's very, very tricky. Or we'll keep them on for a while and then they start to improve and we're like ready to discharge them, and then they fall and something happens and we keep them on longer. And Medicare will say at any given time, if they didn't have a life expectancy of 6 months or less, they don't qualify for hospice. So it's really tricky. It's very, very tricky.
And can I just say, for someone who caregave for someone who had Alzheimer's for 16 years, that's a very long time, and her progression was very slow, obviously. And so, I really have an issue that I've since learned of this one size fits all for, to say, well, this is generally what happens to people with dementia. Well, you can't generalize it because everybody's, some people get dementia early onset and they die very quickly.
Yes.
Some people get it very very, a long time. Like my mom got it in her early 70s, and it lasted a very long time. And so I watched her, but I watched her so carefully. Like I didn't want her to live past where she should be living. Who would want that? That would be cruel. Right? And so I really
You have a good attitude, Susie, but not everybody feels that
No,
way.
I understand that. And it can go either way. Some people push their family member out the door, kick them out, where they're old and they have
They're
dementia.
old,
And I've seen that too. It happened in our family, right? But can I ask you one other, professional question? And I'm going to get a little bit, selfish here with my question, but I think a lot of people will benefit from this, is that when my mom, after her second, she was discharged too early on that first hospitalization. She had to go back, and then she was discharged. And long story short, but she ended up having to go to a emergency hospital because they, for some reason, didn't send her back to the regular hospital. Mm-hmm. And she ended up in a very small emergency hospital here in Los Angeles that I didn't know that they were notoriously not good. And I had already, at that point, said, I gave a directive of no intubation, no more intubation. I do not want her intubated. If she can't breathe on her own, then she cannot breathe on her own. And so when I got to the hospital, guess what? They had intubated her. So I get a call from the doctor, the ER, because they told me to go home because there's only one ER doctor, and they would call me. The next day, not that day, the next day I get a call from the ER doctor to say, your mom is on life support. What do you want to do? Well, okay, I didn't know she was going to be on life support. That's not the last I heard, but let me get my family together. And, of course, we don't want to keep her on life support. Anyway, long story short, my family comes together. We say, of course, we don't want her on life support. Take her off of the breathing tube. And I say, one of my questions is, how long do you think it will be? What should we expect? And, he said, in the state she's in, 2 hours a day tops. So, and so they had turned off her G-tube. They turned off any oxygen, everything, nothing. She had nothing. 4 days later, and I know we talk about Rally, and I know what Rally is. Well, first of all, let's just preface this by saying my niece came, she said, oh, Nanny's not feeling anything. They've got her on a fentanyl drip. And I was like, why is she on a fentanyl drip? And I called the doctor, and he said, oh, because she's allergic to morphine. Well, first of all, she's not allergic to morphine, okay, but why is she even on? She's not in pain. Mom wasn't in pain. And if we're letting her die naturally, if it was, and I'm learning all these terms, if it was, a lack of, what is it, oxygen, when she has oxygen.
Hypoxia?
Then that would be one thing. But I get that. But it wasn't that. There was something wrong. Something hit me wrong about it. So 4 days later, we're sitting vigil with her, and my nephew's there, and we all love her so much. And she looked like she was dying. Like her mouth was like, the jaw was down to her belly button, right? And we were like, just... I literally, my daughters and I were like pushing her over to the other side, like, it's okay, we love you, go, and I mean, my daughter suffered incredible, horrible, depression after that, because she felt like she was like accomplice, trying to kill my mom before she was ready. And my mom, out of nowhere, my nephew said, Aunt Susie, I don't think Nanny's dying, look at her. And this is like at 3 a.m, and my mom is like wide awake. She's like, hallelujah, I'm hungry. And I'm like, oh my God. I go, Mom, you're a troublemaker. You're a freaking troublemaker. What is going on here? Right? I call the doctor. The doctor tells me that he said, what? I've never seen this. He goes, well, first of all, I just want you to understand that by now her organs are starting to shut down and there's no turning back. I said, okay, well, can we test that? Just so I know that that's the truth, is that they have shut down. And he said, yeah, we can do that. So my daughter and I went to like a local hotel just to take a shower. By the time we got back, and he said he was going to take her off of the fentanyl for now. And so by the time we got back, my mother was back to the jaw down to her belly button. And we said, why, what, okay, is this that she was rallying? What's going on? The nurse comes running and she goes, oh, taking your mom off of fentanyl, doctor's orders. And I said, well, I thought she was supposed to be off of fentanyl. No, he came this morning to see her and he said to up the fentanyl every half hour. And then when he came to see me, he said, so you're right, your mom's organs haven't shut down. So I'm going to start the feeding tube back up and we'll release her and get her back to and put her in hospice. That's when hospice came into the play. So this thing about...
And then she lived longer after that?
6 months.
6 months.
So, I mean, I've never worked in the ICU, but I think it's pretty standard to put somebody who's extubated onto some kind of a drip because they could experience respiratory crisis. And even if a person is actively dying, we still want to make sure that we're managing any symptoms that they're having so that they can be comfortable.
Right.
So I think that's pretty standard, but it definitely sounds like she was probably a little over-medicated.
When they took her off the ventilator, she was breathing fine. Her oxygen was fine, and in fact, he said, everything's back to normal. I goes, I've never seen this before.
And he literally said, Penny, he goes, I've never seen this before. It's a miracle. It's a miracle, like that. And I was like,
I can't believe
what planet am I on?
I know. I can't believe they intubated her when you I mean, I believe you.
Twice. Well, that she ended
when
up being
you
intubated
told them
3
not
times.
to, and I feel like you have a lawsuit. You're like, what the hell? You were her. I'm assuming you were her healthcare representative, right?
Conservator of person legally, yes. I went and
mean, I don't understand how they were doing all of these things, even when you expressly said don't. It's one thing if you don't say do it, like if you don't say don't do it because they're going to err on the side of life. They always do. But if you're saying don't do it and then they do it, I mean, that's unethical. And I'll tell you something else about withdrawing. So, and you were comfortable with it, and that's great. But sometimes people have a really hard time withdrawing. It's easier to say, don't do it, than it is to say, take it out. Because when a person has an event, and you don't do an intervention, they're dying from that event, right? They're going to die from whatever happened to them. But when you, say, put in a feeding tube and then you feed them for a week or two, and then you're like, ugh, things aren't going well, let's pull the feeding tube. You're so far away from that event that it now feels like you're starving the person to death. And you made the decision to do that. And it's so much more personal and, it's just a harder thing to do than to just say don't do it in the first place.
Right. And I would have, listen, I'm not a doctor, but I would have known that if my mom stopped eating, if she went like this, turned her head. But my mother was like a baby bird. It used to break my heart because I'd come in and go, morning, mommy, I'm here. And she'd have, as you probably know as a nurse in hospice, because she was on NPO, there was like clogs of mucus that were stuck to the top of her mouth in the back of her throat that I had to pry out first. Because she was so uncomfortable.
Because they weren't doing it.
She would open her mouth up like this, like a little bird, and go like that to show me. I go, I know, I'm going to get it out. I'll get it out. And then I'd give her juice. She was just, there was no life until I walked in. And then I'd give her juice and she'd go, like that. It's heartbreaking.
Yeah.
It's heartbreaking.
My dad was he loved food too. He grew up really poor in Texas, and then he went in the military and really made a good life for himself. And worked at Boeing for a long time, and died when he was 69. And
it's so young.
He loved to eat, and that was the one thing we always say hospice did for us was when he was in the hospital, he was on a fluid restriction, he was on a diabetic diet, he was just miserable. And as soon as we got the hospice consult, I was like, here's your Dr. Pepper. Called my sister.
Yes.
We need a big, huge Vente Starbucks stat. We went to an all-you-can-eat buffet that's called the Golden Corral. It's like the all-you-can-eat meat buffet. We piled that plate with meat, took it back to him. He had a really great last meal. My sister and I still morbidly joke that we think we might have killed him with that last meal because it was just outrageously huge. But
what a way to go.
He ate it, and then he told the nurse that evening, I'm about ready to hang it up. And she went to go get some lorazepam for him. She came back in. He was having agonal breaths and he died. None of us were there. We'd already said goodbye. The plan was to take him home the next day. I was going to be his hospice nurse. We were going to take him home. I was completely blindsided. I had no idea that he was going to die that fast. I couldn't believe it. But it was the way he wanted to go. He was just ready. He was like, I'm out of here.
Look,
that's so important. It's like, we interviewed people that have been on MPO that, have had to do it, that are, cognitively very healthy, and said nobody wants to live like that. That is not a quality of life. And especially if you are at the end of your life, in your last chapter, in your epilogue, really, there's nothing, that is a visceral life thing is to eat. It is the last joy that we have next to music and those and touch. And it was like, why would you want to take that away from anybody? It doesn't make any sense to me, you know.
They give death row prisoners their final last meal. They give death row prisoners their last meal, anything they want. Why do you think they do that? Because as a human being, that's their last joy, and so why would we deprive our loved ones anything but that? It does not make any sense.
That is
in order that they'll live an extra day.
Yeah, that's one of the big myths about hospice, and obviously it wasn't a myth in your case, Susie. It was your reality, but that we starve people, and no, we want people to enjoy whatever they want to have at the last part of their life. Usually they don't want too much because they're dying, and their dying body doesn't need food. But we encourage them to eat whatever they want. Like, you don't need to be on a diabetic diet anymore if you're on hospice. You can have whatever you want, and food is love. Like, we celebrate with food. At funerals, we eat food. At weddings, birthdays, it is love. And it's the one thing that family can do for their person. You don't have to be medical to give somebody food. You can give them, but a lot of times people have a hard time letting go of food when the person is dying and feeling like now that they're not eating, they're going to starve to death. And that's going to be painful. And we say, no, they're not going to starve to death. They're going to die from their disease. They're not going to die from starvation. It's just part of the process.
It makes sense when you're ill. Like, when I'm ill, I don't feel like eating. Right? So,
exactly.
And I'm not going to have, my family's not going to come and go, you have to eat this. No, I'm going to, it's like, you don't want to eat. You don't feel like it. If you'll
close your mouth.
When I'm depressed, I don't want to eat. Like, you can't get a morsel in my mouth when I'm depressed. That's just the way it is.
I'm the opposite, man. I'll eat everything in the damn house if I'm depressed.
I know. There's two ways to go. There's both ways. It's either like me, Don knows me forever. I'm like, I can't. He'll go, do you want a little? No, I don't want anything. Like, I cannot eat when I'm depressed. But I mean, I looked for those signs in my mom. I looked for those, and I knew I was, those are things that as a human being, that's instinctual. Like, if someone doesn't want to eat, why would you force them unless they were, unless you had a doctor going, listen, this is a little baby that has to have this nutrition, and then you would do it, intravenously, whatever the case may be. I'm getting off topic, but the point is what else? Anything else you want to say about our conversation? And I really am so appreciative. I could talk to you for like 2 more hours, just so I could just be cathartic with you, so you can go, oh my God, you poor girl, because because when you were writing back to me, I was like, oh my God, she doesn't know me. She's thinking I'm like crazy. I didn't do my research. I mean, honestly, like, you have to. I encourage you to watch our documentary, because I'm very proud of the experts that we aggregated, who are truly, just brilliant, genius people that have been doing this for decades, who know the industry, know the business of the industry, that part of it, and the things that we're up against. And their only goal is for the quality care of our, it really is it's a humanity problem. It's a problem. It's what we're talking about is humanity. And people have lost that for the aged, and for people that are disabled. There's a lot of stigma and a lot of disregard because there's a lot of misunderstanding. So So do you have anything else you want
to have that opportunity to have the type of care that you give, the type of hospices that your world. We want everyone to have that opportunity, because they don't right now. And I think that's our goal.
Yeah. And we exist, and we're not like the red herring. There's more of us than the bad ones. If you have a bad one and you look for the bad ones, you're going to find all the bad ones. But there are many more really great hospice agencies. People who go into hospice mostly go into it because they do care about other humans and want to provide compassionate care for them at the end of their life. And it's really disheartening to know that there are not only these agencies that are bad, but the people who work for them. That breaks my heart to know that there's these nurses or social workers that really don't give a damn about the dying people. And it's really hard to hear that. I know it exists, but in my experience, and I've been in this for decades too, I haven't met a whole lot of people who weren't really good at what they do in hospice, and all the agencies I've worked for or worked with have been fantastic. So, I think that the most important thing is, again, just people really need to know what their rights are. Make sure that you advocate for yourself if you're not getting the care that you want for your person. And that doesn't just go for hospice. That goes for anywhere, whether your person's in a nursing home or in a hospital or wherever they are. If they're not getting good care, you advocate. Nobody cares about you or your person more than you do. It's just important to be able to stand up for yourself and say, this isn't right. And you know what? What is it they say? If it quacks like a duck and walks like a duck, it's a duck. If you have a bad feeling about something that's going on, you're probably right.
So I agree.
So,
what do we do about the people that don't have advocates? That's the thing that breaks my heart, because so you've got and that's why that's why this neglect and this abuse can go on, because many people don't have it. Even if they have families, their families don't understand what can go wrong. So they figure they're in good hands. Like, I used to say on my podcast when I got my mom into this 5-star facility here in Los Angeles, I can sleep at night now. My mom's being well taken care of. Thank you so much. I feel like I was so proud of myself for getting her in there, right? And we don't know.
Yeah,
we don't know. So what? Any?
I don't have the answer. I don't have the answer for that. I don't know, because again, it's like, I've had patients who had guardian ad litems. They had no one to advocate for them. And I've had fantastic guardian ad litems, which are legal guardians, who did advocate for their person. They cared about the person. And then I've had some that they didn't give a shit about them. They were just collecting a paycheck. You report them. That's all you can really do. I don't know. That's the only answer I have. I don't know what the answer. I think, like I said, the healthcare system is broken. It's just broken. It's everything. It's not just hospice. It's not just the nursing homes. It just goes deeper than that. It's just really broken.
Hey, listen, thank you for what you're doing out there. Like, you have such a good following, and that is fantastic, because, listen, nobody wants to talk about death. You're talking about it. And I, as a person who have been scared of dying since I'm 3 years old, my first anxiety attack was like asking my dad, where do you go when you die? And he was like, you have 97 more years, get back to bed. And I was like, but I need to know. I want to understand. I don't get this heaven thing. I'm not sure. Do we dress up? Do we go to school? What do we do? I was very, very disturbed by this whole concept. And, as everyone knows, my mom and I had a pact. We're not dying. That's for other people, right? So it was a joke. And of course, but, I think that we all do not embrace it. And when I say that my mom taught me how to die, that's no small potatoes. That was a huge thing. And it was, and as one of my other guests told me, who was a doula, said, when the time comes, you're so strong, you're going to see what a beautiful experience it can be. And it was. And I was so glad I was there with her. Like, I wouldn't trade that for anything. And, so what you're doing is to talk about it and normalize it is such a gift. So thank you.
Thank you for having me on. I really appreciate you inviting me on.
Thank you. All right.
We were very happy to have you. Yes.
Yeah.
This is a conversation that should keep going. We should keep this alive, because we have so many loved ones, our loved ones, and then ourselves. This is for everybody. because
Yeah.
unless you're in the top 1%, everyone's going to have to deal
Yeah.
with this.
Don't do
So,
like me. Don't do la 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 la. Open up and
Everyone's
listen.
going to, you can't be in
Yeah.
any percent. 100% of us are going to
100%.
deal with death, whether it's
Yeah.
somebody that we know or we care about or ourselves.
Right. Right.
Yes, absolutely.
And yeah. Well, we'll just tie it all up, Dawn. Bring it home.
Absolutely. Well, this is in the long run. Really, this is really all about love, isn't it, Susan?
Yes, it is always.
Yes, and that is because love is powerful, love is contagious, and love conquers all. So we thank everybody for watching, listening today. If you like what you see, like us, subscribe, do all those fun things, and definitely visit Hospice Nurse Penny. We'll have all her information up in the show notes.
Yeah.
And anything else, Susan?
No. Go on and have a great day, and we'll talk to you next time. All right.
Absolutely. Take care, everyone. Bye-bye.
Bye.